بسم الله الرحمن الرحيم وبه نستعين. السلام عليكم everybody. Today presentation we'll talk inshallah about cholinergic and anticholinergic drugs, actions on the exocrine glands, central nervous system and neuromuscular junction. As we have said in our previous presentation, we are going to classify the actions of these drugs as clinical uses or indications, side effects or undesirable action, or contraindication where the drug should be avoided in a certain condition. We are going to speak about the action comparative way, where we are going to compare the effect of cholinomimetics with those of cholinolytics in the same time. So first we are going to talk about the actions on the exocrine glands. Before we are going to talk about the actions, we know that cholinergic drugs, they increase the excretion of all exocrine glands through stimulation of the muscarinic receptor type 3 M3 receptors, as we have said in the previous presentation. Stimulation of these M3 receptors will stimulate GQ proteins, which in its turn will stimulate the phospholipase C enzyme, which is present in the membrane. Phospholipase C will act on inositol diphosphate to produce 2-second messenger diacylglycerol or DAG, and IP3 inositol triphosphate. This inositol triphosphate will leak into the cytoplasm, where it will act on certain receptors present on the sarcoplasmic reticulum, IP3 receptor, and this IP3 receptor will open calcium channel. Calcium will rush out into the cytoplasm, and this will cause excretion of glands. Okay, so this is the generally how they produce cholinergic drugs. The increase in intracellular calcium which will result in a release of the gland. So first we'll talk about the effect on the salivary glands. As we know, salivary glands, they have a function of lubrication, produce lubrication of the mouth. As well, they produce a protection because they contain certain antibacterial and antivirus. وكذلك they are involved in digestion. They contain certain amylases and so on. So salivary gland is important function. Salivary glands, they produce lubrication of the mouth to protect the mouth against infection, and as well they are involved in some forms of digestion. Cholinomimetics or acetylcholine-like drugs, they will increase excretion of the salivary glands, and this is known as salivation. So we'll expect that cholinomimetics, they increase salivation. Okay, this salivation can be a side effect and it can be an indication. Okay, a side effect, that means that if they are used for any other purpose, we expect that these drugs will produce salivation, okay, as a side effect, or toxicity, for example. So this is a side effect. Also, they are indicated in cases where there is decreased salivation. Of course, the increased salivation, therefore they are indicated in cases where there is low salivation, as in case of what's known as Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease in which the body will consider salivary gland as a foreign body. It will form antibodies, and this antibody will attack the salivary gland, destroying them. Therefore, in Sjogren's syndrome, usually the patient is suffering from very severe dry mouth. Okay, so in this case what we do, we give him cholinomimetic. Like what? Like pilocarpine. We give pilocarpine orally, and as well civimellin. Okay. What's the difference between both? We give pilocarpine and civimellin. What's the difference between both? Pilocarpine, as we know, it is a cholinergic alkaloid. It is a natural plant. Civimellin is a chemically produced. It acts as an agonist at M1 and M3 receptor, and we expect therefore that this civimellin will produce less side effects than pilocarpine. Okay. Of course, these drugs, by acting as an agonist at all muscarinic receptor, they produce many other side effects. So the patient who is treated for Sjogren's syndrome with pilocarpine and civimellin, we expect that they would have abdominal pain due to increase in the intestinal motility, as we have said in the last presentation. They produce flushing of the face because they produce vasodilatation of cutaneous blood vessels in the face. They will increase urination, as we expect, because they will increase the contraction of the trousers muscle and the relaxation of the trigon muscle, as we have explained in the last presentation. And they can produce as well nausea. This is common side effects of treatment with pilocarpine or civimellin in patients suffering from Sjogren's syndrome. Of course, these side effects usually they are intolerable and they will decrease sometimes compliance. Okay, so this is the first group, which are parasympathomimetics. Parasympathomimetics in this case, as we have said, they will increase salivation. This is a side effect. It can be used in cases like Sjogren's syndrome, where there is a decrease in salivation and severe dry mouth. On the other hand, atropine-like drugs or parasympatholytics, they produce exactly the opposite effect. They will decrease salivation. Once they decrease salivation, they produce what's known as dry mouth. This is dry mouth. This is the same thing. Dry mouth is a side effect. It's a very common side effect with atropine-like drugs. Therefore, if I use atropine-like drugs in the treatment, for example, of diarrhea, we expect that they can produce a dry mouth as a side effect. This dry mouth is applied clinically in pre-anesthetic medication. These are, as we will see later inshallah when we talk about C.N.S. drugs, these pre-anesthetic medication usually they are given before the general anesthesia. They are different medications. One of them is the use of atropine-like drugs. Use atropine or hyoscine. Why they give atropine or hyoscine? Because they will decrease secretion in the respiratory tract, and therefore they will prevent laryngospasm. Laryngospasm can take place during general anesthesia because of the excretion of the respiratory tract. This is very dangerous. That's why they give atropine or hyoscine before induction of general anesthesia to prevent the spasm in the larynx, and therefore will prevent any danger on the patient himself. Okay, so these are the effects of parasympathomimetics and parasympatholytics on the salivary gland. Next, we'll talk about their effect on the lacrimal gland. Well, lacrimal glands are the glands, as you can see here, which provides lubrication to the eye. Lacrimal glands are glands which provide lubrication to the eye. Therefore, parasympathomimetics we expect they will increase lacrimation. they will increase lacrimation or excretion of the lacrimal glands. These, as we have said, they can be a side effects of treatment with parasympathomimetics if they are not attended for effect on the lacrimal gland, or they can be an indication where there is a decrease in lacrimation or dry, sandy eyes. This is known as xerophthalmia. Xerophthalmia. Xerophthalmia can take place during Sjogren's syndrome, as we have said earlier. Sjogren syndrome, usually these patients, they suffer from xerophthalmia and xerostomia as well. Xerophthalmia and xerostomia, because as we have said, this Sjogren syndrome, it is an autoimmune disease in which the body will consider salivary gland and lacrimal gland as foreign, and it will form antibody which will destroy the lacrimal gland and the salivary gland. In this case, the same, we use pilocarpine, which is given orally, pilocarpine, or cevimeline, given orally, as we have discussed before. Okay, so parasympathomimetics, they increase lacrimation. This can be a side effect, very common side effects of this treatment of these drugs, and it can be an indication when there is dry, sandy eyes, as in case of xerophthalmia induced in Sjogren's syndrome. Pilocarpine or cevimeline are given as a drug of choice in this case. Okay. And opposite exactly in the parasympatholytics or atropine-like drugs. So atropine-like drugs, they produce the opposite effect. Atropine-like drugs, what they produce? They decrease lacrimation. Decrease lacrimation, this produce dry, sandy eyes sensation. Okay, this is very common side effects, and it has no clinical application. It is a commonly side effect and it has no clinical application. Okay, now, so acetylcholine drugs, they increase lacrimation. It has clinical application in treatment of xerophthalmia. And atropine-like drugs, they decrease lacrimation and they produce dry, sandy eyes, and these are side effects and they have no clinical application. Okay. Next effect, we'll talk about the effect of these drugs on the sweat glands, As you know, sweat glands, they have the function of decreasing body temperature, sweating, and decreasing body temperature. As we know that sweating itself, it will decrease body temperature through the evaporation of the sweat and cooling of the skin, and therefore decreasing body temperature. Parasympathomimetics, they increase, as we have said, excretion of all exocrine glands, including sweating. So they increase sweating. Okay. This increased sweating has no clinical application. It is only a side effect. So therefore, we expect that if we use parasympathomimetic for any certain condition, they will produce increase in sweating. Okay. On the other hand, atropine-like drugs, they produce the opposite effect. Atropine-like drug, sorry. On the other hand, atropine-like drugs, they will decrease sweating. So what will happen by decreasing sweating? That means the skin will become very dry, hot skin. When you touch the skin, you find it hot and dry, and as well they will increase the core body temperature. Okay, therefore atropine-like drugs, by inhibiting sweating, they will prevent evaporation of the sweat over the skin. Therefore the skin will become very dry and hot, and as well body temperature will be increased. This is the side effects, which is usually dangerous in young children, because young children usually they have small surface area. Therefore atropine-like drugs, they produce very clear increase in body temperature and very clear dry skin. Okay, so atropine-like drugs, they inhibit sweating, and they can produce very dry hot skin, and they can increase body temperature. So these are the effects of cholinomimetics and parasympatholytics on sweating, which always, as we have said, they are side effects and they have no clinical application. Next is the effect of cholinomimetics and cholinolytics on the gastric secretion. As we have known that parasympathomimetics, they increase the gastric secretion. This increase in gastric secretion is a side effects. It has no clinical application. On the contrary, parasympatholytics or atropine-like drugs, they will decrease the gastric secretion. For this effect, decreasing gastric secretion, they are utilized in treatment of different different conditions of peptic ulcer and gastroesophageal reflux. Gastroesophageal reflux, which is known as heartburn. In this case, we use the M1 blocker, selective N1 blocker, like Parkinsonism and Anticholineric. Okay, therefore atropine is not used anymore because of the many side effects, because atropine will block all muscarinic receptor M1, M2 and M3, and therefore this will result in many side effects related to blocking of all these muscarinic receptor. So in this case we use the selective M1 blockers or anti-muscarinic M1 blockers like Parkinsonism and Anticholineric. Why? Because they produce more selective action and less side effects. Okay, so these are the actions of on exocrine glands. They have very important clinical application and many side effects and contraindication. We'll talk now about the actions on the central nervous system. Central nervous system contains many muscarinic receptors, especially M1, M4 and M5. They are involved in many central actions, including memory, cognition, learning, etc. Where parasympathomimetics or cholinomimetics, they have said that they are involved in memory and in cognition and learning. Why they said that? Because they found that in Alzheimer disease, the well-known Alzheimer disease, which will affect short-term memory. In Alzheimer disease, there is loss of cholinergic transmission or neurons in the basal forebrain. People who suffer from Alzheimer disease, they suffer from a damage of cholinergic neuron in the basal forebrain. That's why drugs which increase level of acetylcholine centrally, they are used for treatment of Alzheimer disease nowadays, like rivastigmine, and donepezil. These two drugs, they are anticholinesterases. With central effect. That means they increase the level of acetylcholine in brain. And that's why they improve memory in people with Alzheimer disease. However, this effect is limited, of course. It will not stop progression of the disease. Maybe in the next few years we will see the development of allosteric agonists, allosteric cholinergic agonists. There are now many drugs under clinical trial for their use in Alzheimer disease. It may take years before these drugs are introduced into market. Okay, so these are cholinomimetics. They are used in treatment of Alzheimer disease. On the other hand, we expect that anticholinergics or atropine-like drugs will have the opposite effect, i.e. they decrease memory and cognition. Well, actually, there are no clinical studies which indicate whether the atropine-like drugs will affect memory in human. But there are many studies in animals, like one study which proved that M1 blocker, like elbirenzepine, will decrease spatial memory of space in animals. Of course, as I have said, this is an animal study and does not prove that anticholinergic that can decrease memory in humans. Okay, so this is first. Parasympathomimetics can improve memory, and that's why they are applied in treatment of Alzheimer disease, while parasympatholytics, they have no known action. Okay. Second effect, centrally, parasympathomimetics, they increase the tone of smooth muscle tone, skeletal muscle tone through the extrapyramidal system. As we know, through the extrapyramidal system, in the substantia nigra, there is a balance. Extrapyramidal system. Extrapyramidal system is responsible for the tone of the skeletal muscle. In substantia nigra, cholinergic mechanisms, they increase the tone of the skeletal muscle, while dopamine inhibits the tone in the skeletal muscle. Therefore, cholinergic stimulation at the substantia nigra they increase the muscle tone, they make the muscle tone more, and in this case they are contraindicated in Parkinsonism, because in Parkinsonism there is disbalance. In Parkinsonism there is disbalance between dopamine and acetylcholine in substantia nigra. In this case, if the person is given parasympathomimetic or cholinomimetic, his muscle tone will be increased and the rigidity of muscle will become more. Of course, on the other hand, anticholinergics, by blocking anticholinergics or atropine-like drugs, by blocking muscarinic receptor and substantia nigra, they will decrease muscle tone. They will have the opposite effect. They will decrease muscle tone. That's why they are used in treatment of Parkinsonism. One of the group of drugs which are used in treatment of Parkinsonism. Okay? Therefore, atropine-like drugs, by blocking dopamine receptor, by blocking cholinergic receptors, substantia nigra, they will decrease in muscle tone, and they are used in treatment of Parkinsonism. Maybe the most famous example is trihexyphenidyl, and benzotropine. These are anticholinergic drugs which are used for treatment of Parkinsonism. What they do, they block the acetylcholine muscarinic receptor and substantia nigra, therefore they inhibit the muscle tone and help in the treatment of Parkinsonism. Okay? So these are the central application of cholinomimetics and cholinolytics. So what are their clinical application related to neuromuscular junction? Of course, neuromuscular junction contains only nicotinic receptor. So we expect that acetylcholine, which we know it has nicotinic effect and muscarinic effect, will produce action at a neuromuscular junction. Okay? Or drugs which inhibit metabolism of acetylcholine. Acetylcholine metabolism, which are the anticholinesterases. Which are neostigmine, which we talk about them in previous presentation, pyridostigmine, okay? These are, we said, they are peripherally acting, they are quaternary amine, they have peripheral effect, they have no central effect. Therefore, they are used in problems related to the neuromuscular junction. So maybe the most famous example is their use in treatment and diagnosis of myasthenia gravis. What's myasthenia gravis? Myasthenia gravis is an autoimmune disease. What happens in myasthenia gravis? It is an autoimmune disease. What does it mean, autoimmune? The body will consider nicotinic receptor as antigen. Nicotinic receptor which is present in the body the body will consider them as antigen. So the body will produce antibodies for this antigen, and this antigen antibody reaction will result in destruction of nicotinic receptor. طبعا in the neuromuscular junction. So nicotinic receptor, which are responsible for the contraction of the muscle, will start disappearing, will be destroyed. So what will happen? Will happen weak muscles, skeletal muscles. Skeletal muscle contraction will become weak. Okay? So in myasthenia gravis, it is an autoimmune disease. What does it mean, autoimmune disease? The body will consider nicotinic receptor at the neuromuscular junction as antigen. It will produce antibodies against this antigen. These antibodies antigen reaction will result in destruction of the nicotinic receptor, and of course no nicotinic receptor, no muscle contraction. Therefore muscle contraction, muscle activity will become very weak. This is known as myasthenia gravis. In myasthenia gravis we use anticholinesterases. We use anticholinesterases for the diagnosis and treatment. For the diagnosis and treatment. Okay? We know how we do that. So therefore anticholinesterases like neostigmine and physostigmine, neostigmine and pyridostigmine, neostigmine and pyridostigmine, they are used for the diagnosis and treatment of myasthenia gravis. How we do that? So we said in myasthenia gravis there is loss of nicotinic receptor. Myasthenia gravis, the disease, there is loss of nicotinic receptor. So what will happen? First? يحصل loss of activity in small muscles first. Loss of activity in small skeletal muscle. Like skeletal muscle of the eyelid. So the skeletal muscle of the eyelid will lose contraction. This will produce what's known as ptosis. This is the very first signs that the person is suffering from myasthenia gravis. And then this effect will involve other. It is a progressive disease. It progresses to other larger skeletal muscle, producing paralysis of all skeletal muscles. So what they do at the beginning, they give hydrophonium. Hydrophonium, as we know, it is anticholinesterase. It is anticholinesterase of very short duration of action. It acts only 4 minutes. Okay, few minutes. So what they do to this patient who is suffering from ptosis, they give him hydrophonium intravenously. So what will happen? Either immediately بيحصل improvement at the ptosis will disappear, no ptosis. In this case, this is the diagnosis of myasthenia gravis. Why? Because hydrophonium, by inhibiting cholinesterase, will increase the level of acetylcholine at the eyelid, and this will improve contraction of skeletal muscle of the eyelid, and the ptosis will disappear. Okay? Okay. Now, if ptosis is left, is not removed, in that case, the person is not suffering from myasthenia gravis. It is another neurological disease. It's different. Okay? So, hydrophonium is used for the differential diagnosis of myasthenia gravis. How it is given? Is given intravenously. So what will happen? If quick improvement of ptosis takes place, this indicates that the person is suffering from myasthenia gravis. Why? Why? Because when we give hydrophonium, it will increase the level of acetylcholine in the skeletal muscle and the skeletal muscle of the eyelid, so ptosis will be removed. Okay? Otherwise, if the ptosis has not been removed by hydrophonium, that means the patient is suffering from another neurological disease other than the myasthenia gravis. Okay? Now, if the person is diagnosed to have myasthenia gravis, in this case, he is given neostigmine or pyridostigmine. These are anticholinesterases, as we have said. They have generally a peripheral effect, they have no central effect, and they can improve skeletal muscle contraction. Of course, they produce many side effects related to the accumulation of acetylcholine, because they will lead to accumulation of acetylcholine throughout the body, and acetylcholine, we have said, has nicotinic effect plus muscarinic effect. Therefore, we will see nicotinic effect by improving skeletal muscle activity, but as well we will see muscarinic effect like gastrointestinal cramps, like increased gastric secretion, like meiosis, like diarrhea, like nausea, and many other side effects. Okay? So these are the uses of cholinomimetics in the treatment and diagnosis of myasthenia gravis, and especially the anticholinesterases. On the other hand, the anticholinergics or atropine-like drugs, they have no role in myasthenia gravis, except that some of them they can block, some of them they are not very selective. They can block nicotinic receptor. Not all of them. Some of them they can block. They are not very selective in blocking muscarinic receptor. They can block nicotinic receptor. That's why they are contraindicated sometimes. Contraindicated in myasthenia gravis. Some of them, beside blocking muscarinic receptor, they can block nicotinic receptor. That's why they are contraindicated in myasthenia gravis. Otherwise, atropine-like drugs, they are sometimes used to treat cholinergic side effects or muscarinic side effects, because they block muscarinic receptors. Okay, so these are the effects of cholinomimetics and cholinolytics on the neuromuscular junction. They have very important application in the diagnosis and the treatment of myasthenia gravis. Okay, so by this we have finished talking about the actions, indications, contraindications, and side effects of cholinomimetics or acetylcholine-like drugs and cholinolytics or atropine-like drugs. So, in very briefly, I have put all the indication and contraindication in one table. So, on cardiovascular system, parasympathomimetics, they have, as we have said, no clinical application. They have no clinical application, but they can decrease the heart rate and they can decrease the conduction through the AV node conduction. We have said that they can inhibit the SA node and they can inhibit the AV node conduction. On the contrary, parasympatholytics or atropine-like drugs, atropine is used intravenously in certain types of heart block, especially with sinus bradycardia, as we have said. Why? Because it will increase the conduction through the AV node. On smooth muscles, we have said that the parasympathomimetics, they improve tone of smooth muscles in the GIT, and therefore they are used in paralytic ileus, and the tone in urinary bladder, and therefore they are used in post-operative urinary retention. Anticholinergic, atropine-like drugs, on the other hand, they are used to decrease intestinal motility. They are used as antispasmodic, and the most famous propantheline, and also gunna they use as antidiarrheal mixed with opioids like atropine. Okay, exocrine glands, we said they are used in xerostomia and xerophthalmia as well. Xerostomia and xerophthalmia. And in this case we used civimilline or the bilocarbine. Both of them, they are used orally in treatment of Sjogren's syndrome. Anticholinergic drugs or atropine-like drugs are used as pre-anesthetic medication, in this case to prevent laryngospasm. And benzodiazepine is used in treatment of peptic ulcer and is selective M1 blocker. On the smooth muscles of the eye, we have said that cholinomimetics, they produce meiosis, therefore they are used pre-surgically, especially acetylcholine, and we said they can decrease intraocular pressure, and therefore they are used in treatment of glaucoma, and most famous using bilocarbine. Atropine-like drugs, on the other hand, they produce mydriasis, and therefore they are used for ophthalmic examination, and the most famous example used cyclopentolate because it has a short duration of action. On respiration, we have said that smooth muscles of respiratory tract, cholinomimetics, they produce contraction of the smooth muscles of the respiratory tract, produce bronchoconstriction. They are used in diagnosis of airway hypersensitivity, and so we said that methacholine is used by inhalation in the diagnosis of airways hypersensitivity. Atropine-like drugs, they produce bronchodilation, therefore they are applied in bronchial asthma and chronic obstructive pulmonary diseases. And we use ipratropium by inhalation. We don't use atropine because ipratropium does not produce inhibition of ciliary movement and does not produce dryness of bronchial secretion. Of course, each one is used, each group is used for the treatment of toxicity with the other group. Therefore, parasympathomimetics are used to treat overdose toxicity with anticholinergics, and anticholinergics are used to treat overdose toxicity with cholinergic drugs. On C.N.S, we said cholinomimetics, they are used in treatment of Alzheimer disease, and we have taken example domperidone, Anticholinesterase, dombizil, and rivastigmine. These both anticholinesterases, they improve memory in case of Alzheimer disease. On the opposite, on CNS, we said atropine-like drugs that are used in treatment of Parkinsonism because they will decrease the tone of the skeletal muscle. And the most famous example is trihexyphenidyl, trihexyl or trihexyphenidyl. Also, they are used as a prophylaxis in motion sickness, and the most famous example is scopolamine, which is taken an hour or so before riding any moving object. On neuromuscular junction, we said that the cholinomimetics, like anticholinesterases, they are used in the diagnosis and the treatment of myasthenia gravis. وكذلك they are used to prevent or reverse the blocking due to competitive neuromuscular blocker. Okay, so these are the most major indications of cholinomimetics and cholinolytics. On the other hand, their contraindications are many, and I have put them in a table. Parasympathomimetics in general, they are contraindicated in hyperthyroidism. This is expected because they will increase the secretion of thyroid gland, and this will make hyperthyroidism worse. Of course, they are contraindicated in bile ulcer disease because they will increase gastric secretion. They are contraindicated in asthma because they produce bronchoconstriction. They are contraindicated abnormal heart rhythm because they affect conduction through AV node. They are contraindicated coronary artery diseases. They are contraindicated in fainting, in hypertension or hypotension, and Parkinsonism because they will increase in muscle tone, in convulsion and seizure disorder, and ulcerative colitis. Okay? Now, parasympatholytics, on the other hand, they use with caution in heart ischemia because they will increase the heart rate, increasing oxygen demand. Therefore, they should be used with caution. They are contraindicated in myasthenia gravis, as we have said, because some of them they have the ability to block nicotinic receptor. They are contraindicated in glaucoma because they produce mydriasis, decreasing the flow of aqueous humor, increasing intraocular pressure. They are contraindicated in enlarged prostate or prostatic hypertrophy or hyperplasia because they will decrease the flow of urine. They produce urinary retention. They are contraindicated in hypertension, in vesical urinary tract blockage, in heart failure, in severe dry mouth, in hiatal hernia, in severe constipation, in liver disease, and in Down's syndrome. So these are generally the general contraindication of cholinergic and anticholinergic drugs. By this, I hope that I have finished the most important principles of cholinergic and anticholinergic drugs. I would like to thank you very much for your attention. If you like my presentation, don't forget to press like, and don't forget please to share with friends. Please subscribe to my channel. Wish you all the best luck. Wassalamu alaikum wa rahmatullah.